Dr. Grewal, I will let you share your slides. She's going to be presenting on mobile opioid treatment programs. So take it away.
Can everyone see my slides?
Yeah, it looks good.
Okay. Oh, 1 second. I lost my screen here. Okay. All right. So yeah, today I'm going to be talking about mobile opioid treatment programs. So learning objective for today is to review the clinical purpose and services provided by these mobile OTPs, review how mobile OTPs fit into the continuum of caring for patients with opioid use disorder, recognizing some federal and state guidelines that, particularly for mobile OTP operations, and then just reviewing some common challenges that these mobile OTP units face. So first, why is it important to talk about, these mobile OTP units? So, as we're all aware, opioid crisis is a major public health emergency. Traditional OTPs, tend to be limited by location and accessibility. And these mobile OTP units are an innovative solution to reach underserved populations. In 2023, there were over 84 deaths from opiate overdose alone. And then fewer than 1 in 5 people with opioid use disorder actually get treatment with medications. And then, driving distance to get medications for methadone at, traditional OTPs vary largely depending on, where the individual is residing, whether it's rural or urban setting. So nationally, on average, individuals drive about 15 miles one way to get to an OTP. And in rural areas, they may spend about up to 50 minutes driving one way to get to an OTP to get treatment. So these mobile OTP units are also known as mobile medication units, MMUs. Mobile units that, these are particular units that provide treatment for opioid use disorder. And then other services that include is like counseling, behavioral therapy, other general medical care, and social support. They're licensed under federal and state OTP regulations. So mobile units are satellite extensions of OTPs to help reach rural and underserved communities that lack local clinics and help bring treatment directly to patients in a local but centralized location. They can even help bring treatment to jails so individuals don't experience opiate withdrawal. Currently, there's only 6 states that utilize mobile OTP units to bring treatment to jails. They also help overcome barriers such as lack of transportation and unstable housing. Many individuals that even have a car can't afford to pay, for gas to get to their treatment centers. And then also you can use mobile OTPs to reduce travel times, thus reducing the time they take away from other responsibilities, such as, maintaining employment or from childcare. So services offered by these mobile OTPs is, of course, medication dispensing, daily methadone dosing. Some clinics provide physical and mental health evaluations. Some offer primary care services such as wound care, vaccinations, reproductive health services, screenings for things like HIV and hepatitis C. They also can provide counseling and case management. They also sometimes provide, things for harm reduction like, Narcan or clean syringes. And then case management can also help, provide referrals for housing, employment, and other supportive services. So, in terms of regulations, as of September 2024, only 17 states had mobile OTPs, and this was because of, very strict regulations. In Wisconsin, there's only 1 OTP that has a mobile unit. Other bigger, larger OTP they have bought the mobile units and customized them. However, because of regulations and just cost effectiveness, they haven't used them. Yeah, so in 2021, the DEA lifted a 13-year restriction on new mobile OTPs. And then also additionally, each mobile unit had required its own separate DEA registration. And this change in 2021 allowed OTPs to just modify their existing licenses. And then the new regulations also permitted mobile units to offer a full range of OTP services, like the initial assessments, medication inductions, counseling, case management, and recovery support. And then they also allowed increased telehealth integration, enabling patients to get screenings and even like initial methadone dosing via telehealth. And lastly, they also provided more flexibility in dispensing take-home methadone doses based on individual patient assessments and stability. So these mobile units, they could be like an RV or a bus that's customized to have like a waiting room, exam rooms, bathrooms, and the bathrooms are utilized for providing urine samples for the UDS. And here is a picture of a local mobile TP that's here in Wisconsin. They're usually staffed by licensed counselors, nurses, and sometimes even clinical providers such as MDs, NPs, or PAs. They have real-time access to their home EHR integrated via satellite. They also have GPS tracking and video monitoring for safety and compliance. The back units where medical care is being provided, that's monitored, and even where the driving, the front part of the RV is also monitored. And so this provides fixed scheduling and on-demand deployment, like in case it's needed for jails or something like that. So benefits of mobile OTPs, it definitely increases access to treatment, it reduces overdose deaths, it decreases the travel burden on patients, and then it increases, outreach to high-risk populations such as, individuals with unstable housing and incarcerated individuals. So challenges, like we talked about before, regulatory complexities and DEA compliance. There's a high startup cost for operations. For our local mobile OTP that's here in Wisconsin, they were not, they were losing money for about a year when they started, and only recently started making, somewhat of a profit. They also ensure, consistent follow-up care for patients. And, sometimes they do face community resistance. For example, the local mobile unit here, they set up they started going to Baraboo, and they were using a city parking lot to provide treatment. However, the local community initially, they were like very against it. And then and lastly, in terms of challenges, security and security and safe medication transport is another concern. Funding is usually through federal grants, but can also come from state opioid response funds, Medicaid coverage, and from public and private partnerships. So the local mobile OTP I was talking about is through PASS. Their main clinic is off of East Washington Avenue, but they have just one mobile OTP right now, which first goes to Portage. They're there Monday through Friday, 6:30 a.m. to 9, and then Saturday and Sunday from 6:30 to 8 a.m. And then that same unit goes over to Baraboo, and they're there Monday through Friday, 9:30 a.m. to 11. They are going to be having a second unit, which is going to serve Watertown and Beaver Dam. Currently, the PASS mobile OTP serves about 60 patients a day, and I forgot to mention earlier, for individuals that don't have insurance, they can pay $17 just like they do in the clinic out of pocket to get methadone in the mobile units as well. Oop. So just to wrap it up, mobile OTPs are scalable. You can like PASS is doing, you can, if you have the patient population, you can always add more units. It's a patient-centered response to the opioid crisis. It helps reduce barriers and deliver a life-saving care where it's needed the most. And continued policy funding and innovations are essential to addressing the opioid crisis.